Friends, today I'll be discussing endoscopic evacuation of chronic subdural hematoma, how I do it, and the experience. The management options for chronic subdural hematomas are presented here. I will focus on endoscopic treatment. This presentation is divided into two parts. First covers how I do it, and the second involves discussion on key points on the management. Here is a short video of chronic SDH, which has solid or organized component. Preoperative CT scan shows hyperintense hematoma. And this is post-op CT scan, which shows complete hematoma evacuation. A 3 centimeter incision with 2 to 3 centimeter bony opening is made, and the dura is opened up to the bony margins. Dura being opened up to the bony margins. This is important. Solid clot is being evacuated using targeted suction technique, in which the suction tip is taken directly onto the solid component of the hematoma, and therefore it can be aspirated. Unlike a conventional burr irrigation technique, in which the solid clot removal becomes difficult, here the suction is onto the clot. So with fragmentations of hematoma, this can be removed very well. So suction irrigation can be done. Later on, we have used suction irrigation in a single instrument, which reduces the operating time. So this is a bridging vessel which could have been injured by burr technique, but with the endoscope, this was coagulated and cut. The distal part of the hematoma cavity, which is difficult to visualize with the endoscope even, can be visualized when this novel retractor is placed, which can retract the brain parenchyma, and distal hematoma cavity is visualized. So this is the end of surgery. This video is of the bridging vessels, which is identified by the brain being pulled towards the dura mater. The bridging vessels, if present, are coagulated and cut, and these vessels could otherwise be injured when you use blind suction irrigation technique. This is a CT scan of a patient who had bridging vessels, which can be identified by the area of chronic subdural hematoma, which is pulled towards the dura mater. Here you can see that this brain is being pulled towards the dura mater, so also here. So if you find this finding, then you should suspect that there can be a bridging vessel. Whereas on the other hand, if it is a septa, then the brain is not pulled towards the dural margin. This is the incision, which is at the most lateral part. Dura is being removed up to the bony margin. Clot is being evacuated. Again, using same targeted suction. The solid component comes out when the tip is taken to that point. Now you can see the bridging vessel, and you can very well see that the brain is being pulled towards the dura mater. And after removal of this, then this falls back. There is another bridging vessel which also has been coagulated and cut. So that is the advantage of endoscopic surgery. in normal borehole irrigation, this vessel could have been injured. This is post-operative. Here are some of the examples where endoscopy is especially useful. Although the endoscopic treatment can be done in all type of chronic subdural hematoma, but when there are septations, you can see that there is a septa here. So if there are septations, if there is organized blood, this is a solid blood lying on the inner membrane of chronic subdural hematoma, or there may be combination of septa and a organized clot. And here one can see that this is a bridging vessel. So if there is a bridging vessel, the brain is being pulled towards this. So when the hematoma enlarges, this bridging vessels can rupture and it causes acute on chronic subdural hematoma. Secondly, this bridging vessel can get injured when you go for blind suction irrigation. So this should be coagulated and cut, which can be done under the endoscopic visualization only. This cannot be done when you use borehole irrigation technique. See, there are septations here, but the brain is not being pulled. So this is how you can differentiate between septations, fibrous septa, and the bridging vessels. When there is a bridging vessels, the brain is pulled towards the durameter. This is a organized clot. So these are absolute indications for endoscopic treatment. This is again a solid organized clot where only targeted suction can remove the hematoma. Another case in which we did endoscopic treatment. The other indication for endoscopic treatment is when you have layered or laminar hematoma. Septations may divide the cavity either from anterior to posterior or from superficial to deep compartment. Here you can see that the septa is dividing cavity from anterior to posterior side, and here you see that there is a superficial cavity, there is an intermediate cavity and a deep cavity. So there can be multiple cavity and which are divided from superficial to the deeper part. So whether it is anterior to posterior septations or superficial to deep, all these need to be removed. Otherwise, one cavity may remain or more than one may remain, and then this will enlarge after surgery and will give rise to recurrence. So this visualization is possible in endoscopic treatment only, which is not possible in the burr hole. If it is not, if this layering is present when where there is a burr hole, then you can maybe identify the layers. But if it is away from the burr hole side, then the endoscopic treatment can find out the other cavity. Endoscopic treatment is particularly effective in thick inner membrane as they often have additional hematoma cavity located deeper to the thick membrane, or there is a solid component. This membrane hinders brain re-expansion and is the cause for incomplete hematoma removal. Effective management requires splitting and removal of thick membrane to drain the inner cavity and facilitate brain re-expansion, thereby reducing the risk of recurrence. This scan shows a thick inner membrane denoting another cavity deeper to this. Here you can say that there is a cavity and there is a thin membrane and there is another cavity which has blood seen deeper to this layer. The brain parenchyma was not seen. That denotes that there is another cavity which should be opened. Here we see that there is a thick membrane, so there should be another cavity deeper to it, and it prevents expansion of the brain. So we removed this. In the surgical technique, position of the burr hole is very important. It should be placed on the most curved portion and the lateral part of the skull, to provide the optimum access to the maximum length of the hematoma cavity. Placement of the burr hole on flat surface or medial margin of the skull should be avoided as shown in the images. Here you can see this is anterior side, this is posterior side of the skull, and this is a chronic subdural hematoma. Burr hole should be placed as shown here as green arrow or a black arrow posteriorly. So on most curved portion or as lateral as possible. If you make burr hole more medially, not as lateral, then with the rigid scope you will enter straight into the brain parenchyma. It will be very difficult to visualize the whole hematoma cavity. And likewise, if you enter at the flat surface as shown by this red arrow, then also you will enter in the brain, and it will be very difficult to visualize the whole hematoma cavity, or else you have to remove a large bony opening. If the chronic subdural hematoma is not reaching up to the surface on anterior or posterior, then you should use the superior side burr hole. So this is a superior, this is inferior side of the skull. So if the chronic subdural hematoma is reaching here, the most curved portion as lateral as possible, that should be the place where you should make the burr hole opening, and not medially towards the midline. If you make it here as shown in red, then there is a problem, and you should not make it on the flat surface, even if it is the thickest portion of this subdural hematoma. So not only the site is important, but the shape is also important. The way you open the bone, the bony opening should be trapezoid shape, which means that the inner table is more widely removed to enable the straight trajectory into the maximum length of the hematoma cavity. Our modification involves additional drilling of both inner and outer table, which further enhances access to the full length of the hematoma cavity. In this image, you can see this is the outer table. So the less of outer table is removed, more of inner table is removed. So this is outer table, inner table is more removed, trapezoid shape of the burr hole, so as that you can enter into the hematoma cavity as much length as possible. In our modification, we drill the inner table also, we drill the outer table also, so that you get a better angle and you can reach the hematoma cavity using a rigid scope. But there are limitations of endoscopic treatment. These limitations are difficulty in visualization of the distal hematoma cavity, especially when the cavity is long and curved. Second limitation is difficulty to place the endoscope and instrument in a narrow cavity. So we develop a novel retractor to address these limitations, which gently retracts the brain and allows the distal hematoma cavity to be visualized. So here is the big subdural hematoma, and the hematoma at point E is difficult to be visualized using this technique. And even if you place the burr hole at as lateral as possible, drill the outer table and the inner table both, still E point, that is most distal part, is difficult to visualize because the overlying brain is covering the vision. So this novel tubular retractor can retract the brain and allow visualization of the distal portion. This is the novel retractor which is placed. So this can retract brain and allows more space and also allow visualization of the distal part. This is the novel retractor, thin silicone tube with tapered tip, and there are 3 sutures placed on the outer side to prevent migration. It enhances visualization of the distal hematoma cavity and provides adequate access for the endoscope and the instrument when the cavity is small, as we have already discussed. Additionally, it prevents lens swelling, protects brain and the hematoma wall from injury. It facilitates rapid and safe suction irrigation of the hematoma. So this is the novel retractor with tapered and inner, which is good for ease of introduction in the cavity, and these are the sutures which prevent migration of a novel retractor. Some special instruments are required in the endoscopic treatment, and these are curved suction tip, which allows solid clot to be evacuated. The other one is the suction irrigation cannula, where catheter is passed through the opening of the suction tube, as described by Dr. Manas Panagiri. The third is the suction irrigation can be made by joining the two suction tubes. An indigenously developed curved tip wire insulated with the infant feeding tube, it can also be used, which can be used for coagulation of the vessel, which are located deep and located at the corner, which are not accessible by the routine endoscopic forceps. The last one, which is very important, is the novel retractor, which helps in retracting the brain and also allows more space to work within this hematoma cavity. So this is suction irrigation. The infant feeding tube is passed through the hole. In other, we joined two suction tubes, smaller for irrigation and larger for suction. It allows very rapid suction irrigation, and this is a wire which is insulated by the infant feeding tube. The distal end is curved so that it can reach where the breathing vessel is. The proximal end also is curved to allow manipulation of the tube. Hemostasis can be achieved using angle tip bipolar forceps or insulated angle tip wire. We have operated over 400 cases of chronic subdural hematoma. Endoscopic treatment was found to be particularly effective in approximately 44% of these cases. The novel retractor was required in over 15%, addressing the challenge of narrow cavity and the curved distal hematoma cavity. So there was situation in which endoscope was especially useful when there was organized clot, there was septa, there were breathing vessels, and in some case a novel retractor was very useful, and these cases were when the hematoma cavity width was small, or there was rapid re-expansion of brain, which trapped the distal cavity, so you need additional space to work with the endoscope, and this novel retractor provided that. These are preoperative CT scan showing hematoma, post-operative showing complete hematoma evacuation. Another case, preoperative and post-operative. So our recommendation for chronic subdural hematomas are endoscopy or burr hole plus drain when there is a single cavity with liquid clot confirmed by MRI. So sometimes it is difficult by CT scan to find out whether there is a single cavity. So if you have done MRI and there is a liquid clot and there is only one cavity, there are no multiloculations. In such case, even burr hole technique can be performed if you don't know endoscopic treatment. Endoscopic treatment is especially beneficial when there are septations, breathing vessels, thick inner membrane, organized or solid clot. Craniotomy is required in all above conditions when you have septations, breathing vessels, thick inner membrane or organized clot, when facility of endoscope is not available, and it is also indicated when there is a calcified hematoma. Middle meningeal artery embolization is required when there is a thick outer membrane, there is a recurrence, patient is on antiplatelet or antithrombotic drug, and in poor general condition. For detail, you can watch our videos and read our articles. I'm thankful to my teachers. Thank you.